In our last sketch, we illustrated a few causes of thrombocytopenia, or decreased platelet numbers. In this scene, instead of platelet number, we're going to look at platelet function. Disorders of platelet function are called qualitative platelet disorders. For some reason, your platelets are misbehaving and don't want to form clots. Which, let's face it, sounds pretty annoying. I mean, the platelets are all there. Just clot. Or plug, whatever, try harder. As with other causes of isolated platelet dysfunction, the only abnormality you'll see on coagulation testing is an increased bleeding time. Platelet numbers are typically within normal range, as are coagulation studies like PT and APTT, indicating that clotting factors are normal and functional. This is a platelet problem only. The symptoms that result are very similar to the other types of platelet disorders we've covered, including von Willebrand disease and ITP. We call this a platelet-type bleeding, and it involves bleeding into the skin and mucous membranes, which can manifest as easy bruising, petechial rash, and nosebleeds. This is in contrast to coagulation disorder bleeding, which typically involves bleeding into soft tissue, muscle, and joints. So remember this superficially bleeding kid as we go over each of the following platelet disorders. If platelets aren't functioning, expect bleeding. Qualitative platelet disorders can be broken down into congenital and acquired causes. Acquired causes are by far the most common, so let's start there. First up, uremia. In the setting of renal dysfunction, the kidney is no longer able to adequately filter urea, so it builds up in the circulation instead. At Sketchy, elevated blood urea nitrogen is symbolized by an elevated fast food bun bag. And in this scene, it's being used to distract the dog that dwells in the lot behind the baseball field. The kids call him the Beast, and they've lost countless balls behind that fence. Like the latest one you can see in the foreground. Just another casualty. Now, too much urea in the blood wreaks all kinds of havoc on the body. Think back to our chronic kidney disease sketch, where we illustrated all the signs and symptoms of uremia, including pericarditis, neurosymptoms, asterixis, all kinds of stuff. That majestic stegosaurus in the back with the broken plates represents platelet dysfunction. And we've brought back this dysfunctional dino here on the kid's shirt. Uremia is one of the classic causes of platelet dysfunction, especially in the hospital, where many patients often have significant kidney injury. All of those uremic toxins that accumulate in the circulation mess with platelet aggregation and adhesion, two critical steps in the process of forming an early clot. The symptoms that result consist of those platelet-type bleeding symptoms we discussed earlier, including bleeding into the skin and mucous membranes. In order to reverse the qualitative platelet dysfunction and get those platelets back to work, the treatment of choice is dialysis. Dialysis removes those uremic toxins from the body and allows the platelets to get together with each other again. Next up is trauma. It may seem simple, but it's a big one. In fact, coagulopathy is a part of the so-called triad of death. Coagulopathy, hypothermia, and lactic acidosis, commonly seen in patients with severe trauma. While the platelet dysfunction caused by severe trauma has many mechanisms, lactic acidosis and temperature dysregulation likely lead to impaired platelet aggregation and adhesion, and therefore prolonged bleeding. The last acquired platelet defect we'll cover in this sketch is diabetes. Maybe a few of those Dia-Sweeties candies will get the beast's attention. Besides causing a million other physiological changes, diabetes mellitus can also affect platelet function. However, unlike the other conditions we'll discuss, diabetes causes thrombotic complications instead of bleeding. So send in the dirt clods. It's thought that chronic hyperglycemia causes dysregulation of several signaling pathways, resulting in hyperactive platelets. This overactivity of platelets leads to increased risk of thrombus formation, including inside the coronaries, resulting in myocardial infarction, symbolized, as always, by a broken heartstring. This qualitative platelet dysfunction may also explain why diabetic patients seem to be resistant to antiplatelet medications such as aspirin and clopidogrel. Let's move on to the congenital causes of qualitative platelet dysfunction. These are rarely encountered in the real world, so pretty much the perfect question for step one. The three most commonly tested inherited disorders of platelet function are Bernard-Soulier syndrome, Glanzmann thrombasthenia, and Wiskott-Aldrich syndrome. For Bernard-Soulier, let's focus on that St. Bernard. This syndrome is an autosomal recessive qualitative platelet disorder caused by a deficiency of GP1B receptors on the surface of platelets. So, because it's an autosomal recessive, we've brought in our recessive shy kid, cowering in fear. And because GP1B isn't working properly, we've got a kid falling off the wall, wearing the number 16. Or 1B, that is. Glycoprotein 1B normally helps platelets bind to von Willebrand factor expressed on the vascular endothelium. Normally, when the vascular endothelium is damaged, von Willebrand is exposed and grabs onto GP1B on the surface of platelets, starting that whole platelet adherence activation thing, vital to the formation of the platelet plug. No GP1B on platelets, and von Willebrand factor has nothing to grab onto. That means no adherence, no platelet plug, and lots of bleeding. And what better visual metaphor than a kid unable to adhere to the wall? Bernard-Soulier syndrome also belongs to a group of syndromes known as giant platelet disorders, aptly named for the incredibly large platelets seen on peripheral blood smear, some of which can even be larger than red blood cells. That's because GP1B is also located in the platelet cytoskeleton and is involved in the process of platelet budding from megakaryocytes. Therefore, when GP1B doesn't exist, platelets can't break off from the main megakaryocyte, leading to giant platelet formation. Hence the giant satellite dish, or giant plate, as it were. To diagnose Bernard-Soulier syndrome, look for a lack of platelet aggregation in response to ristocetin, an ingredient which normally causes von Willebrand factor to bind GP1B. Since GP1B doesn't exist on platelets in Bernard-Soulier, there's nothing for von Willebrand factor to bind to, and platelet aggregation won't occur. This is considered a negative ristocetin test, and is reenacted by the kid at the top of the wall as he fails to grab onto the wrist of his falling comrade. Be careful though. A negative ristocetin test also occurs in von Willebrand disease, since not having von Willebrand factor will also keep the von Willebrand factor glycoprotein 1B complex from forming. To differentiate Bernard-Soulier from von Willebrand disease, add some normal serum to the ristocetin test sample. Normal serum contains normal amounts of von Willebrand factor, which will return platelet aggregation to normal in a patient with von Willebrand disease, where the defect is a lack of von Willebrand factor. This was depicted by that cirrus-evoking beverage, spilling over towards the aggregated air hockey pucks. Conversely, the addition of normal serum changes nothing in Bernard-Soulier. See how that cirrus beverage is not really helping matters? Since there are adequate amounts of von Willebrand factor already present in Bernard-Soulier syndrome, adding more doesn't correct the dysfunction. Glanzmann's thrombasthenia is our next autosomal recessive qualitative platelet disorder. Notice the GT we've incorporated on this rusty old car. That's GT for Glanzmann's thrombasthenia. Again, we've drawn in an autosomal recessively shy kid, receding in fear as the beast approaches. This time, the dysfunctional glycoprotein on the platelet surface is GP2B3A. Look above, that's 2 balls and 3 strikes. Normally, GP2B3A binds to fibrinogen, allowing platelets to come together to form a platelet plug. As such, the rescue operation involves a fibrous-looking branch of fibrinogen. If he could only... You're killing me, Smalls! In Glanzmann's, that whole binding to fibrinogen thing we talked about? Yeah, not happening. And yet again, you can't form that platelet plug, resulting in the usual platelet-like bleeding pattern, which consists of bleeding into skin and mucous membranes. Interestingly, this same mechanism is actually used as a clinical therapy. The antiplatelet medications abciximab, tirofiban, and eptifibatide are often used to prevent further cardiac complications in heart attack patients. These work via blockade of those same GP2B3A receptors. Back then, we were intercepting fibrinogen fries. Check out that sketchy farm sketch on antiplatelet medications for those sweet, sweet deets. An important diagnostic finding in Glanzmann's thrombasthenia is the inability of platelets to clump on a non-anticoagulated peripheral blood smear due to the lack of platelet-to-platelet adhesion. Unlike Bernard-Soulier, however, patients with Glanzmann thrombasthenia will have a positive ristocetin test, since von Willebrand factor and glycoprotein 1B are both normal. So grab onto that wrist. Okay, last one. We've saved the best for last, since technically, Wiskott-Aldrich can classify as both a quantitative and qualitative disorder of platelets. Wiskott-Aldrich syndrome, WAS, is a rare X-linked recessive immunodeficiency syndrome caused by a mutation of the Wiskott-Aldrich syndrome protein, WASP. Very clever protein naming people. So we've drawn in some Wiskott wasps, in addition to our recurring X-linked symbol, which usually involves someone hiding behind a large X of some kind. Wiskott-Aldrich syndrome protein is an important cytoskeletal protein in multiple cell lines, including B lymphocytes, T lymphocytes, and platelets. The key findings in Wiskott-Aldrich form a classic triad: eczema, thrombocytopenia, and combined B and T cell immunodeficiency. It's all here in the drawing. You've got the eczema from multiple wasp stings. Then there's thrombocytopenia, or low platelet numbers, which is represented by the rusty, beat-up plates on the ground. Platelet plates. See what we did there. They're beat up and chewed to bits because the deficiency of WAS protein causes platelets to not only get deformed, but also smaller than normal. This can be seen under the microscope on a peripheral blood smear. That's the qualitative platelet defect, but there's also a quantitative one. And what I mean by that is thrombocytopenia. You see that macro cage with plates inside? Let that remind you that these tiny deformed platelets are gobbled up by macrophages in the spleen. As a result, you'll also see that classic platelet-like bleeding. Bleeding occurs in 80% of infants with Wiskott-Aldrich syndrome, though the severity depends on the degree of thrombocytopenia. Those with higher platelet counts may only have mild bleeding, such as petechial rash or epistaxis. However, those with severe thrombocytopenia may have life-threatening GI or intracranial bleeding. In addition to platelet defects, children with Wiskott-Aldrich are also prone to recurrent infections. That's the third part of the triad: immunodeficiency. This is a combined T cell and B cell immunodeficiency, but we'll talk about this more in our immuno unit. For now, just remember the crutches, which symbolize an immunocompromised state. Lots of weird pathogens pop up, in fact, including encapsulated bacteria. B cells are really important for producing adequate amounts of IgG and IgA to fight these bugs off. And that's the end of platelet disorders. Well, not quite the end. You'll see Wiskott-Aldrich again in the immune disorders unit. And now that I think about it, uremia came up in the renal unit. And diabetes, of course, that one comes up a lot. Guess you're never really free of a little platelet dysfunction. At any rate, let's quickly sum up these qualitative platelet disorders. In general, they cause a platelet type of bleeding, which can manifest as petechiae, bruising, and epistaxis. Expect an increased bleeding time with otherwise normal coagulation labs. Qualitative platelet disorders are most often acquired, as is the case with uremia, which inhibits platelet activation and aggregation. Trauma also causes platelet dysfunction from massive inflammation, especially when the triad, coagulopathy, hypothermia, and acidosis, is involved. And don't forget diabetes, which is a switch hitter, causing thrombosis instead of bleeding. And approaching the plate, the congenital platelet defects. St. Bernard-Soulier is an autosomal recessive deficiency of glycoprotein 1b on platelets, meaning they can't bind von Willebrand factor, which usually links them to endothelial collagen. Like in von Willebrand disease, patients will have a negative ristocetin test. Unlike patients with von Willebrand disease, platelets will still not aggregate after addition of normal serum. Just can't quite reach. Glanzmann thrombasthenia is an autosomal recessive deficiency of glycoprotein 2b3a on platelet surfaces, making them unable to bind fibrinogen. Unlike Bernard-Soulier, patients with Glanzmann thrombasthenia have a positive ristocetin test. And finally, let's tie things up with Wiskott-Aldrich syndrome, an X-linked recessive mutation of the WAS cytoskeletal protein that presents with the triad of thrombocytopenia, immunodeficiency, B and T cell, and eczema. And remember, WAS is both a qualitative and quantitative disorder, as the small deformed platelets get macro-caged in the spleen. Platelet disorders. They're hard to pronounce, hard to understand, and even harder to remember. But as the Sultan of Swat once said, there's quantitative and there's qualitative. Quantitative get broken down, but qualitative never clot. Follow these sketches, kid, and you'll never go wrong.